Now, would you consider this proposal? Now, we've been talking about this. When was the first year that this was first introduced?
1992.
Wow, I was my first year out of college. So long ago. Now, would you consider this program more or less comprehensive than Vermont's initial proposal, and more or less comprehensive than the Canadian system?
It is more comprehensive than Vermont, particularly in who is covered, because Vermont left out large chunks of their employers and employees. It is also more comprehensive than most of the Canadian provincial plans, because they do not cover prescription drugs, most of them, and the New York Health Act would.
Well, so we're talking about a plan that's more comprehensive than Vermont's proposal, and now what happened in Vermont?
What happened in Vermont was partly because of the major gaps in their plan. They were not able to capture either the savings that come with a single-payer system, because they still had all the administrative costs of having multiple payers, and because their highest-paying employers were not contributing to the cost of the system, they lost out on a lot of their revenue. The other thing that happened in Vermont is that they have Vermont's economy, not New York's economy, and therefore they had even per capita, a dramatically smaller economy on which to raise the money. Also, their assessment or tax, whatever they were going to call it, as I understand it, was not progressively graduated, and so lower income Vermonters would have been hit with higher rates than they should have been. And put all that together, also in their developing their financing plan, they ignored a lot of the savings that come with a single-payer system, and as a result, the governor had on his desk assessments, taxes, whatever they were going to call them, that were a lot higher than they needed to be and a lot higher than he was comfortable with. Our plan is, for all of those reasons, dramatically better.
Well, now, if it's more comprehensive than the Canadian plan and really more comprehensive than our current Medicaid plan, do you worry about limitations of services or long wait periods?
No.
Why?
Not at all. We have an extraordinary supply of doctors and hospitals in New York. They would have a lot more time to treat patients if they didn't spend a lot of their time fighting with insurance companies. So in effect, that would dramatically increase our supply of healthcare providers. In Canada, there is this myth about wait times. Almost all of that is because Canada is a very sparsely populated country. They have a population smaller than California in acreage that's about 2 or 3 times that of the United States, and it is very difficult to maintain a large base of advanced surgery and the like when you have very few available patients. It is not because of the adequacy of payment under their system. So there really is no reason why that phenomenon in Canada would be replicated here.
Well, I know you're saying it, but when we talk about specialty fields like neurosurgery and orthopedic surgery, the doctors in New York State that would perform some of those services disagree with you, and they're against it. I'm seeing statistics in Canada where you have to wait 39 weeks to see an orthopedic surgeon, 27 weeks to see a plastic surgeon, 24 weeks to see a neurosurgeon, 19 weeks to see an ophthalmologist. So I mean, well, I know you're saying it, but the doctors in New York State that are charged with delivering those services disagree with you.
there are people who publish scare statistics like that. When you try to find out where they came from, they turn out to be overwhelmingly mythological. That's number one. Number two, Canada has more doctors per capita than we do. The Canadian health system is phenomenally popular in Canada, and if it had all of those problems, it would not be so popular that neither political party dares to do anything that would be seen as undermining it. If you talk to Canadians,
I do when I
that,
see them in New York hospitals.
it's a phenomenally popular program. And the reason Canadians sometimes come to U.S. hospitals is really the same reason why people in, say, Plattsburgh may come to Albany Medical Center for complex surgery, because there isn't the population base in Plattsburgh or any small town to sustain an academic medical center. And so, yeah, there are Canadians who live closer to a U.S. academic medical center than to a Canadian one. So they may come across the border, but it's not because their health plan doesn't pay enough to sustain a good healthcare system.
Well, actually, the people I've spoke to from Canada at the Hospital for Special Surgery talked about the long wait periods to see an orthopedic surgeon, and they could come to New York to one of the best hospitals in the world and get those services immediately versus waiting.
Well,
that being said,
I can't account for the views of the individual, or I don't know how many individuals you spoke to. I've never seen evidence of that kind of phenomenon on anything resembling that kind of scale in Canada. And to the extent they have weight problems, they are overwhelmingly for the reasons that I described.
Richard, when was the last time there was a fiscal impact study or an economic analysis done regarding this legislation?
Let's see, this is June, I guess 15 months ago. An economic analysis of the plan was done, and I can share a copy with you if you like. It's also available online by the head of the economics department at UMass and Amherst. It goes through the economics of this plan in great detail. That's where my $45 billion savings number comes from. None of the information in that report is particularly novel. It all is gathered from well-established sources and all makes perfect sense. I mean, the fact that we spend an enormous amount of money on insurance company and healthcare provider administrative costs, that's not a surprise to anyone, particularly hospital administrators and doctors. Practically any doctor I talk to complains, or their lobbyists complain about the amount of time they have to spend on the phone with insurance companies fighting about whether something will be covered. All that disappears under the New York Health Act. What we now spend on health care and the various elements that would go into reducing that are all well established, and calculating out what the premium rates would be is fairly simple arithmetic if you've got standard tables about income distribution in New York, all of which is government information.
I'll be back and I'll keep that.
All right. Well, you know, I'm reading a report from Canadian News right now that seems to favor my wait times versus what you're actually saying, and I would think the Canadians know how to review their own system. But moving on, are there any cost containment provisions in this legislation?
I'm sorry, could you say that again?
Are there any cost containment provisions in the legislation?
Yes. Well, first of all, for many healthcare providers in New York, reimbursement rates would go up, as they should, because doctors treating the wealthy and the poor would not be treated differently under the plan. And you can make sure, you can be pretty certain that people with wealth and power will make sure that their doctors and hospitals are well paid, and my doctor and my constituents' doctors will benefit from that. the mechanisms for making sure the care is medically necessary would be the review and appeal mechanisms that now exist in the system. What you would not have is insurance companies making a living out of turning down payment, whether that turn down is justifiable or not.
Okay,
To me,
Richard.
that's not cost containment. That's just profiteering at the expense of healthcare.
All right. I think I have about 10 seconds left. Thank you, Richard. As always, I appreciate our dialogue on this issue, and I suppose we can do it again, basically the same time next year. Thanks. Appreciate it.
Thank you, sir. Mr. Ra.
Thank you, Mr. Speaker.
Mr. Speaker.
Mr.
Speaker.
Gottfried yield?
Mr. Speaker, I'm sorry.
Oh.
Could Mr. Rod just hold 1 second? I'd like to ask members of the Environmental Conservation Committee to move to the Speaker's Conference Room with the Chair, Mr. Engelbright. Members of NCON in the Speaker's Conference Room.
NCON
Apologize.
Speaker's Conference Room. Immediately, Mr. Engelbright will meet you there.
I presume
We,
Mr. Gottfried is
1 minute,
Yes.
Mr. Ra. Before you start, we have some entry and exit. Proceed, sir.
Thank you, Mr. Speaker. Just for starters, you cited the number in terms of the savings, the financial savings of this plan. Can you break down at all where, what different things are going to happen that's going to produce those savings?
Yeah, the gross savings would be in the order of $71 billion. Where that comes from is primarily from, I think it's on the order of, I don't have the report open in front of me, about $26 billion in insurance company overhead and profit, and a almost equal amount in healthcare provider administrative costs. I mean, they spend more than that in administrative costs, but this is the chunk that could be relied on to be eliminated if we take insurance companies out of the picture. Several billion in reduced payments for drugs and devices, because the state would now be negotiating prices with drug companies rather than having individual health plans doing that through profit-making PBMs. We've all heard people say that Medicare Part D could save a lot more money if the law allowed the Medicare program to negotiate directly with drug companies. Under the New York Health Act, that would happen. There would be, so those are the major savings. Save about $2 billion that employers now spend running or monitoring their company health plan. On the other side of the ledger, there would be about $26 billion in increased spending for covering care for the uninsured, for paying providers more than we now pay them, for picking up the cost of deductibles and copays, picking up and a couple of other items. Do the arithmetic, that's where the $45 billion net number comes from.
Okay, so as part of that, you mentioned administration, private health care administration costs.
Yes.
So do you know what that $26 billion, what is that as opposed to, that's obviously, that's savings, so that's what we think we would pay under this plan as opposed to if we had our current system still in place. Do we know what that larger number is that would be the administrative cost of private health insurance in it's 2019 that's based upon?
It's based on projections from today's numbers to 2019, and the roughly $26 billion, $20 billion numbers that I cited were what we would be saving. What the administrative cost for healthcare providers would be left over is, I could find you in the report, the administrative cost of the plan itself, which is calculated based on looking at the administrative costs of traditional Medicare and the administrative costs of single-payer systems, particularly in Canada, would be a little under 2%, as opposed to the 12, 15, or 18% of insurance companies today.
Okay, now, in terms of that percentage we're using in terms of the administrative costs under this plan, now, is that just, really the direct administration of the programs like, we currently have with say, our Medicaid programs or Medicare programs? Does that contemplate, say, within Medicaid, our, managed care plans, private administrators that are undertaking that work to process claims for people, or is it just kind of the government side of it, if you will?
Well, it would include the processing of claims. In the Medicaid managed care system, we contract out the running of the Medicaid program by and large to insurance companies called Medicaid managed care plans. They have the same kind of administrative costs that the insurance plans that cover me and you have. In some cases, it's the same company. And so the cost of Medicaid would similarly come down because we would no longer be paying managed care plans to do all of that work that would no longer be getting done. It would cover the simple processing of claims, similar to what is done in the non-managed care part of Medicaid and in what we have come to call traditional Medicare.
Well, I mean, I think the work would still need to be done, correct? It just would be all being done by one entity rather than there maybe being, some private plan that we're contracting out to. And I assume there's also some administrative costs, I guess, within the Department of Health or wherever that is, coordinating eligibility and all of that, and obviously passing along state and federal funds to those providers.
Well, there's a lot of work done by insurance companies that is not done in traditional Medicare or in the Canadian system or similar systems. Whether it's arguing about whether something is a covered benefit, or arguing about whether the doctor you went to is in network or out of network, or the medical necessity of something. All of that goes away. And as it is not, we don't spend money on that in non-managed care Medicaid. We don't spend money on that in traditional Medicare. And by the way, the cost of traditional Medicare, while it has gone up over the decades, has gone up at about 2/3 the rate of the cost of commercial health coverage. And so the efficiency of that kind of system is extraordinarily well documented.
Okay, so just before I move along from the administrative side, I just want to note, and my colleague obviously mentioned the Vermont system, and I know it's not an identical plan, but it's obviously the one example we have of an attempt of a state within the United States trying to do this. And, that was kind of one of their lessons learned, that the administrative savings that they thought they were realized didn't quite end up being there.
Well, that's not the lesson from Vermont. The lesson from Vermont is that if you exclude your highest wage employers, you ruin the system. If in your calculations you ignore the administrative cost savings that you will get, then your cost estimate goes up. And if you do not progressively graduate your tax rates, if you call them that, you will be imposing higher rates on working people and their families. Those are the lessons of Vermont, and the New York Health Act avoids all of those pitfalls.
Well, they may be lessons, but at the end of the day, as they were doing this in Vermont, they still had projections just like this of what their proposed plan was going to do, and many of those things were not realized. I'm looking right at the report and presentation the governor made, and basically he said they had done reports, they assumed hundreds of millions of dollars in administrative savings in year one, and then he said it wasn't practical to achieve it. So I think that somewhat is a lesson to be learned. I do understand your point. Obviously, when you look at medical care, the larger the population, especially maybe if you're talking about wealthier individuals, maybe if you're talking about younger individuals who are need less in terms of medical care, you're spreading the cost wider, and obviously that is going to change the success of this type of program.
Well, the plan is going to cover every New Yorker, not just the young, healthy ones, number one. Number two, Governor Shumlin may not have said that the reason I'm shelving this is because of flaws in the program that my administration put together and because of poor and inaccurate estimates, but that is what happened. He may have pointed to some savings, but his documentation pretended that a lot of other savings were not going to be achieved, and the design of his system guaranteed that other savings would not be achieved, and the design of his revenue package guaranteed that working people would pay more than they had to or should have had to. That's what Vermont proves. And again, Governor Shumlin may not have said that about his own work product, but that's what was going on.
Well, okay, so I want to just move off of the topic of the administrative costs and onto your study mentions an economic impact, basically in terms of job creation versus job loss within the industry. So I just want to ask about that. How many folks within health insurance and healthcare administration related industries do we project might lose jobs as a result of this type of plan?
Well, first of all, I assume we all agree that we wouldn't want to make New Yorkers pay enormous amounts of money and have real barriers to life-sustaining health care in order to keep jobs that aren't needed. I mean, we wouldn't be sustaining this whole industry and all the damage it does to family finances and health in order to maintain a jobs program. I don't think anyone would advocate that.
Nor am I suggesting that.
Right,
I
okay.
think we're talking about
Okay.
an
Factual
issue and how to get to
Yeah.
a solution
Okay,
and how to ensure those 5% or so of New Yorkers who are currently without.
Well, it's,
insurance.
again, it's not just the 5% who are uninsured, it's the 95% almost who have inadequate and troublesome insurance. But the factual answer to your question is that there are about 23,000 people employed in the health insurance industry within New York State.
That is that directly for health insurers, or is that contemplate people in healthcare administration more globally?
Well, that number is people who work either directly on the payroll or contracted out for the insurance company side of the picture. There are more people who our healthcare dollars pay for who work in doctor offices and hospitals fighting with insurance companies. And I would much rather be spending money either on health care or putting that money back in the pockets of New Yorkers so that each of them could buy something with it that was useful to them rather than contributing to two warring armies that don't do New Yorkers any good.
Okay, so I just want to note, I know the report, I guess, the report prepared by Professor Friedman does mention about 300,000 New York residents who would be employed in healthcare administration in New York in 2019.
Although a substantial chunk of them would continue in their work because it takes more to administer a hospital than just billing insurance companies, and that number includes all of the administrative people in a hospital, not just the ones who work on billing. It then estimates what portion of them are doing billing. But what the report also talks about is that if you pump $45 billion back into the pockets of working New Yorkers, that generates a couple of 100,000 jobs in economic activity in New York. You know, when Governor Cuomo talked about putting $1 billion into Western New York, people felt that was just amazing. Wasn't that wonderful? Wouldn't that be an economic shot in the arm, et cetera? We're talking about 45 times that. And if I had a bill that said employers in New York would be given $2 billion in state aid, you'd say, wow, that's fantastic. $2 billion in aid to employers. That would be great for New York's economy. Well, New York employers now waste about $2 billion a year running and monitoring the company health plan. They wouldn't have to do that anymore. They could spend that $2 billion on something else, like salaries for their workers, or hiring more workers, or lowering their prices.
You can come back for a second time,
Thank
Mr.
you,
Rye,
Mr.
if you'd
Speaker.
like.
Thank you, Mr. Gottfried.
Thank you, sir. Mr. Goldfeder.
The sponsor yields.
Mr. Gottfried, will you yield for Mr. Goldfeder?
Certainly.
Mr. Gottfried yields.
Thank you, sir. Just wanted to ask, how does the bill address prescription drugs and as it relates to insurance?
Well, prescription drugs would be fully covered. The mechanism through which they would be covered would be the preferred drug program that exists in part of Medicaid, under which the state is able to negotiate prices with drug companies, and the so-called prescriber prevails rule, which I think most of us strongly endorse, would apply for the New York Health Act, even though it does not apply for my drug plan or yours.
Thank you. On the bill?
On the bill, Mr. Goldfeder.
So I would absolutely agree whether, I'm looking forward to hearing a little bit more and reading a little bit more about this as we debate it. But I agree that on every level, whether it's the health insurance, home insurance, flood insurance, I think the insurance industry is completely broken. And I don't think we're in a place where we can continue to fix it and put Band-Aids on it. We've really got to do something drastic if we're going to make real change to ultimately help the people we represent. What I'm seeing more and more, and I bring this up more because I went through it this week myself, is that insurance companies are now dictating terms of care. Insurance companies are telling doctors which prescription drugs can be used and which ones cannot be used. They're telling doctors, well, if your patient has a certain type of cancer, you can have choice A, choice B, or choice C, and that's it. Now, if you want to do choice D with a little bit of this, health insurance says, look, we're simply not covering it. And if your patient has $10,000 or $15,000 or $20,000 to pay, then you can do what you want. And if they don't, unfortunately, they're going to have to die from whatever disease or cancer that is ailing them. We have a serious problem that requires a serious solution. And so while some people stand up and say, well, this is too big of an idea, this is too far to one ideology or another ideology, it's time to start thinking a little bit differently, because the system right now is not working. Now, unfortunately, my son needed a certain drug this week, and the insurance company said no. They said absolutely not, you cannot have it. The doctor said that was the right drug. The doctor said that's what he needed. And the insurance companies said no. And quite frankly, it's unacceptable. The doctors are the ones who should be providing medical opinions and should be providing medical advice and giving out the care. And unfortunately, it's bureaucrats in some office who are dictating the care for our children when they never spent a day in medical school. They never spent a day studying medicine. They spent time figuring out risk management and how to best make money in their companies. Quite frankly, it's unacceptable. We need big ideas. And so whether this one is it or not, it's about time in this chamber, whether it's about health insurance, whether it's about flood insurance, whether it's about homeowners insurance, it's about time we start holding some of these companies accountable. It's about time we take some of the big money out of the industry and allow those people who are experts to do their job, so the doctors can actually do their job of being medical professionals. And we can finally give the care that our families so deserve. So I want to thank you for your time and encourage my colleagues, whether it's on this or anything else, to think a little bit differently about how we approach every industry in the insurance business. Thank you.
Thank you, sir. Mr. Morelli?
Thank you for allowing the interruption. We now ask members of the Corporations Committee to meet in the Speaker's Conference Room. Corporation in the Speaker's Conference Room.
Corporation Speakers Conference Room. Mr. Barron.
Thank you, Mr. Speaker. You know, on the bill,
On the bill, sir.
during the great debates around the Affordable Care Act, it was noted that 40% of the people that go into bankruptcy do that because of health care costs. It was also noted that many of the insurance companies, most prioritize profits over patients. The New York Health Act prioritizes patients over profits. How could anyone be against a bill that would save $45 billion for consumers, a bill that is said to be universal because of all of the types of health care that it covers, including prescription drugs? How could we be against a bill that would enable every New Yorker to be insured and take the profit out of health care? After the Affordable Care Act, people were praising it for a step in the right direction, but the insurance companies laughed their way to the bank. They made mega profits off that, and my beloved East New York and places like Harlem and Bed-Stuy and Brownsville and other places in New York City and Queens, these communities would benefit greatly from a universal single-payer health care bill. It is long overdue, especially in light of the fact that there's talk now of having for-profit hospitals, of building or a momentum building toward for-profit hospitals. Right now, they're public and volunteer, but now, as it is across this nation, they're now looking toward New York. New York, because of it being a union town and legislative bodies like this, has really minimized, almost eliminated for-profit hospitals. But that notion is coming back now. It started with Pataki, and now Cuomo's trying to sneak it in through other kinds of ways. But we need to look at health care as a human service delivery, a human care delivery, not a profit-making business, as is education. This country has been built on industrial complexes. Industrial complexes. An industrial complex is that marriage between the corporate world and the politician, how they come together to monopolize industries for profits. The prison industrial complex, the military industrial complex, the education industrial complex, the healthcare industrial complex, the sports industrial complex, the housing industrial complex. These are human needs services that our people need sorely, but there are profiteers that are using this to make mega profits at the expense of the people. So I want to commend the sponsor of this bill. It is a bill that I'm hoping catches on across the nation. It is a bill that I'm hoping catches on in certainly other states, but in the federal government as well. When they were debating the Affordable Care Act, it was called for then a single-payer system, universal. They said no. And then we said, well, how about just a public option in the state exchanges along with the insurance companies? They said no to a public option because they want to keep it privatized and they want to maximize profits over the patients, over the people. I applaud the sponsor for this bill.
Thank you, sir. Mr. Ra, on your second.